Okay, so why don't we go ahead and get started. This is Liza Greenberg. I'm Interim Vice President of VNAA, and I'm delighted to have everyone with us today. I want to welcome you to the Home Health Value-Based Purchasing webinar series, which is co-sponsored by VNAA and the Alliance for Home Health Quality and Innovation. And just by way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value of home health care, both to patients and to the U.S. healthcare system, with a focus on quality and innovation. And VNAA is a national organization that supports, promotes, and advances home-based healthcare organizations, and in particular, home health agencies and hospices. This webinar series was jointly created by us to support organizations in the 9 states participating in the CMS Value Based Purchasing demonstration program for home health. And knowing that there's very broad interest in the home health value-based program, the webinar series is open to all home health care agencies and is free to members of the Alliance and to VNAA. The first webinar in the series, which was in February, featured Chris Ataya of SHP, who covered the fundamentals of the home health value-based purchasing program, including measures and the financing structure. And that webinar is available as a recording from VNAA's Learning Management System. The second webinar was Barbara Muntz, who is a senior advisor for CHAP, who covered Home Health Value-Based Purchasing Performance Improvement 101. Today's webinar is the third and will focus on tactics for performance improvement in the context of value-based purchasing. And later this month, we'll be covering Performance Improvement 102 with Margarita Labson of the Joint Commission presenting on customizing your QAPI in a value-based purchasing environment. And so let's move on to today's presentation. I'd like to introduce our speakers. We have 2 presenters from a home health agency, the Norwell VNA and Hospice. And NVNA was founded in 1920. It's the only independent nonprofit home health care organization serving the South Shore region of Massachusetts. It serves nearly 600 patients a day and also offers free community health screenings, educational programs, and support groups. NVNA and Hospice has continuously been named a home health care elite top agency and has been in the top 100 for the past 2 years. Andrea Foley with NVNA has been with the organization for 25 years. She is currently the Director of Performance Improvement and Education at NVNA and is responsible for quality improvement priorities and educational resourcing to support improvement in the organization. She is published in Home Health Care Nurse and is visiting lecturer at UMass. Also, Bachelor of Nursing from Education at Hamm State University and is a wound, ostomy, and continence certified nurse in wound care. Also with Andrea is Suzanne Clark with the NVNA. She's been with NVNA for over 20 years and was a physical therapist in the field for 15 years. She's been the Performance Improvement and Education Department Director for the past 6 years and is currently Staff Development Coordinator overseeing all agency education and training. Suzanne received her Doctor of Physical Therapy in 2007. She's a board-certified geriatric specialist and a certified OASIS specialist. She has developed and presented continuing education courses nationally on home health care and chronic disease. And I'm Liza Greenberg. I'm the Interim VP of Quality for VNAA. And I have a background in nursing, and I've worked with a number of organizations on healthcare quality improvement and performance improvement issues. I worked with VNAA's work group on best practices in developing our 5-star best practice web content that we'll talk about today. So before I get started, let me just give you a couple of notices. One is that we will definitely save time at the end for questions. So if you do have questions, please use the chat box that's in the right-hand corner of your screen. Everyone is muted to prevent background noise, and the call is being recorded. So we will have this recording up on our learning management system in a couple of days. And for those of you who are registered for the call, we'll be emailing the slides out after the call. So with no further ado, why don't we go ahead and get started. Let's see, I've already done the introductions. And what we'll be talking about today is a brief look at performance requirements in VBP. As all of you know by now, one of the unique features of value-based purchasing is that it closely links quality with reimbursement. So organizations will have opportunities for financial incentives or potentially cuts based on your performance in the value-based purchasing demonstration states. I'll be alternating my presentation with comments from the NVNA folks who will talk about how they're preparing in Massachusetts, which is one of the VBP states, and how they're integrating their quality management approaches overall as an organization with new requirements in the VBP program. We'll look briefly at cross-cutting activities that are recommended in our Blueprint for Excellence to improve quality and to really have a fundamentally strong QI program in your organization, and then drill down to some of the specific recommendations that came up through our best practice work group around performance improvement activities. So I think all of you have already probably a laser-like focus on quality improvement. There are no shortage of measures out there or ways that you're being ranked and rated in quality. We've got Home Health Compare. Over the past year, we've rolled in the star ratings, both for quality and patient experience. And because of those, I think organizations are very familiar with national benchmarks on the quality and patient experience that your organization is delivering. What value-based purchasing does is it slices and dices the measures somewhat differently, and it creates state benchmarks that you'll now be working towards. So there are 24 measures within the value-based purchasing program. 21 of them are OASIS and claims and HCAHPS measures that you're probably already reporting. 3 of them are brand new measures. And then you'll be getting feedback somewhat differently under VBP. There's quarterly feedback that goes directly to home health agencies starting in July of 2016, and annual public reporting on the VBP program measure. So that's separate from other reporting that's going on. This is a slide that Chris Ataya showed in his webinar on the intro to HHVBP, but it's the 21 not new measures that you'll be reporting, grouped according to domains of patient experience and care coordination and efficiency. So these are measures that you have been reporting already, some of which are reported in Home Health Compare, some of which are not. And the ones that are not currently reported in Home Health Compare are the ones listed here: discharge to community, care management types and sources, prior functioning ADL, IADL, influenza vaccine data collection, and reasons pneumococcal vaccines not received. Then in value-based purchasing, there are 3 new measures: influenza vaccine for home health agency personnel, so it's looking at your staff, herpes zoster for patients, and advanced care planning. And for the time being, these will simply be reported through a portal to CMS, so it'll be a somewhat different reporting process. And I know that my head has been spinning trying to get up to speed on all the measures applicable to home health. And so I created this table to kind of show the various domains that you all are reporting in and how the different types of measures for different programs interface. And you'll see over on the far side a purple column of Impact Act measures, which are currently under development. And so these are mostly listed at the domain level. The specific measures have yet to be developed by CMS, but starting in 2017 for home health agencies, you'll be reporting Impact Act measures as well, and those measures will be standardized across all post-acute care providers. So for the time being, they're a somewhat separate issue, but you can see that on the horizon there will be more complexity in the measurement strategy. But I think what's helpful in this slide is showing that there's a lot of overlap, which you already know, and it might be helpful in prioritizing what you're focusing on in your quality improvement strategies to look at where are you getting the most overlap in the measures and the similarities across the measure groups. So why don't I stop here and ask the NVNA folks to comment on how you're looking at value-based purchasing and trying to integrate it in the context of all the other quality improvement activities that you're working on.
Hi, this is Suzanne. I first just want to thank you, Liza, and the VNAA for inviting us to participate in today's webinar. We're really very happy to share our experiences today, and we hope that we can be helpful to other agencies on the call. So Andrea and I are going to be talking about some of our performance improvement strategies that we have been utilizing over time and some of the things that we've been focusing on value-based purchasing. So the number one performance improvement strategy that we have really found valuable in our agency is really making sure we involve our staff in the issues facing us and our plans for agency successful. So that involvement of the staff has been, we've been always doing that for years. This is, of course, going through things like Medicare requirements or changes or anything that might be new, such as the value-based purchasing, which our state is now piloting in our state of Massachusetts. So we don't just teach staff how to answer OASIS questions correctly, but we make sure that we are providing training and education to give them a broader understanding of what is happening in the healthcare industry and how it's affecting home care and things that they can do directly that directly relate to the success of our agency, which in turn actually affects their jobs as well, right? So we get that really a buy-in so that they know exactly what they're supposed to be focusing on and how it can affect our agency. So our agency regularly does presentations with the staff, and the one presentation that we do is called Connect the Dots. And in this presentation, we talk about the triple aim. And you may be familiar with this term. It was coined by Donald Berwick, who was headed CMS early in the Obama administration. We have modified his triple aim into a Norwell VNAA and Hospice triple aim for success. The 3 points of our triple aim are excellent patient experience, excellent quality outcomes, and excellent financial management. We then go into depth in our training on all of these different areas to make sure that our staff understands that the ability to be successful to meet the triple aim is really in their hands. They are the ones who need to provide the excellent experience, the excellent care, and to make decisions for efficient use of resources. We go into depth about the HHCAP survey and how the OASIS contributes to our payment as well as our quality outcomes. So that is something, this Connect the Dots that we do regularly. We also include it in our orientation for our new staff coming on. The second area of performance improvement we focus on is close analysis of data. We use SHIFT for our data analysis and for benchmarking. We look at data kind of in 3 different categories, 3 different ways of how we would work on the data. The first one is just looking for those easily fixable outcomes or low-hanging fruit. So this would be an outcome that would be fixed by just a small process change. An example of this would be looking at things like timeliness of care. And do we need to make sure we're doing our process correctly in order that we're putting a note in the chart that a new start of care date was ordered by the physician, was actually being that we're following that process. Otherwise, it looked like we were getting in late if we weren't putting that note into the chart. So that was just a process change that was easily fixable. The second category is really looking at incorrect scoring on the OASIS at start of care. And we do focus on this a lot. We want to make sure that all of our staff have the training that they need in order to utilize the OASIS correctly using the guidance manual. So we may decide to do kind of a broad education to the staff about how to answer a certain question using the guidance manual, and we call these presentations the M of the month. So we do that regularly, choosing ones that we need to work on. But we can also use our data from SHIFT to really target specific clinicians who need training on specific questions. So we're able to use that data in that way to make sure that we are looking specifically at who needs that education. And then the third category is those category outcomes that, when we're looking at analysis and looking at outcomes that we're not doing as well on, those are things that that would take a lot more work. So outcomes that are truly involved in analysis of how we're managing our patients and education to make sure we're providing the best care we can. So, for example, our current analysis actually shows us that our dyspnea scores and our hospitalization scores are those things that we need to work on. We have a current plan in place that's to provide our entire staff education and training in dyspnea, in the assessment, in the documentation, and the management of this symptom so that we can improve our patient care, improve our dyspnea outcomes. And since our patients' dyspnea symptoms will be better managed, thereby our hospitalization rates should also be affected by that, and we will be able to take care of our patients better by keeping them out of the hospital. We have very much used the VNAA Blueprint as well, which I know Liza is going to be talking about in a few minutes, all the resources on the VNAA Blueprint website, Blueprint for Excellence. And then we're also, in this case, we're going to be using our nurse practitioners to provide this training. So we're able to have that resource available to us to provide training to our staff. All right.
Thank you, Suzanne. And this is Andrea from NVNA Hospice. And thank you, Liza and VNAA, for inviting us to participate today. So I wanted to speak a little bit more relative to the technology tactics that our agency is employing to address value-based purchasing. And first and foremost, we're currently looking at a way that we can really kind of drill down more into our documentation within our EMR, and we're currently investigating and reviewing a clinical software system, sort of referred to as a clinical rules engine, and it will overlay with our current EMR, and it will allow us to kind of do a deeper dive into our documentation besides the OASIS. In that, we can be more concurrent and allow for more proactive management of risk and alerts. So for example, for med management, this type of system would recommend perhaps adjustments to medications, something that we may want to consider relative to that patient's comorbidities and make those recommendations to a physician. Monitor, for example, monitor best practices for therapeutic drugs, or if there's some type of therapeutic lab monitoring that needs to be conducted. Again, we would get an alert, so again, we can be proactive in trying to manage that risk that might ultimately cause that patient to be hospitalized. Also, this system could identify high-risk drug combinations. So again, that could be caused by the patient's conditions, and again, give us that alert and risk. So this type of data management system, this technology, we really see as advantageous in focusing our patient care management for the primary care clinician and also for our clinical manager. And just a side note, Liza, I really want to appreciate your tool that really kind of gives the overlay of all the measures that we need to be cognizant of as we enter into this value-based purchasing and making sure that we're addressing all those measures. And I think that tool is a great resource to be utilizing. Also, for technology tactics, we're currently looking at our telehealth system. We've always had telehealth here as a best practice, utilizing that in our primarily in our patients with CHF, COPD, and some with diabetes management. But we really took this as an opportunity to reevaluate our system, and is it meeting the needs and really identifying early patients who are more at risk for hospitalization, and it allowed us to make a change in our equipment. So we're currently changed our system and employing a system that will allow for video monitoring. So we are currently piloting our new system with the video monitoring, and thus we feel that this is going to be able to allow our telehealth nurse to perform a better patient assessment, to be able to triage those symptoms, but most importantly, to really provide that education, that visual opportunity, give that education to the patient, allow for teach back to ensure that they're understanding their instructions and how to best manage their own disease process. So for example, the use of inhalers, how often patients don't receive that type of education with discharge, and we can then be able to make that impact and do that. So we feel that that's a technology change that's really going to be beneficial for us. Also, in our technology tactics, we're currently looking at our EMR system now, and we're working with our vendor to ensure that the data that we have to report on those new measures, that our EMR system can support that. So for example, herpes zoster and our advanced care planning, we want to make sure that that data can be easily collected and retracted from our EMR. So we're currently working with our vendor on that to support that. We've always had a process in place to support the collection of data on the influenza vaccine coverage. Our Board of Health, we house a Board of Health here within our organization, so they have really played an important role in helping to manage that process and collect that data so that we are ready to support that reporting of that measure. I want to comment a little bit more about how we've kind of approached the advanced care planning new measure. First, we recognized early on the education and training needs of our staff in order to support this measure. To be able to really fully address this with our patient population, we needed to start with them first and make it more personal for them. So in that vein, we explored our education and utilizing a tool, a card game called Go Wish. And in this sort of card game, it promoted advanced discussion of end-of-life care with families and healthcare providers. So that was really sort of eye-opening and personalizing their own advanced care planning measures themselves as staff, and then in turn becoming more comfortable with having that conversation and communication with the patient, and thus moving forward with documenting of that so we can report that data. Also in the same vein with supporting the advanced care planning, we partnered with an organization within Massachusetts called Honoring Choices, and they really are an organization that helps support advanced care planning, healthcare proxy information, really developing that type of education. And we had them come to our agency to provide education to our staff and tools for education, and we therefore made some revisions in our patient handbook and admission packet to reflect that advanced care planning information. And finally, I just wanted to echo the same that you said, Liza, relative to value-based purchasing, that as a participating agency within the state that's in this trial period, that we really need to be cognizant of comparing those measures, those state measures. Often we're looking at state and national, but if you're an agency who's currently not in one of those pilot states, you may be more cognizant of national numbers, but those that are in the state really need to be zeroing in and taking that deeper dive to look at how you are comparing to others within your own state. And I think that both Suzanne and I, hopefully we've been able to offer some valuable information relative to PI efforts, education, and technology to help support value-based purchasing moving forward.
Great. Thanks, Andrea and Suzanne. Just for the audience to let you know, there are no slides specific to the NVNA experience, but we're going to be tag teaming back and forth with Andrea and Suzanne, so we'll continue to hear from them about how specific aspects of the value-based program are underway in their organization. So, continuing on, let's drill down a little bit into performance improvement and quality strategies, drawing from the VNAA Blueprint for Excellence. So just for those of you who may not be familiar, the VNAA Blueprint for Excellence is a free website, vnaablueprint.org. It is a continually evolving resource for home health care and hospice agencies. It's based on expert recommendations from work groups, and we periodically convene groups to come together to brainstorm. And what they do is they look at the best available evidence out there on a specific clinical topic or strategy, take what we can from the evidence, and then make recommendations that you really need to get work done in your organization today. So where there isn't evidence, there are expert recommendations on the types of strategies that you can use to drive quality improvement. It's kind of a living document, and we know that there's a huge scope of organizations that are practicing in the field, so you need to kind of look at it based on your staffing needs, your workforce availability, your size, your caseload, and take what works for you and adopt to some of these best practices. So what we're going to present today are some of the recommendations from our work group that you would need to think about how you would adapt it or adopt it within your own organization. So vnaablueprint.org is the main website address, and then we do have some content that's new on specific 5-star best practice activities that is for members only. So going back to our measure list, again, I mentioned that there's a lot of overlap, and you can see that there's clustering around certain areas, and that's what I'm going to talk about today are these areas: patient experience, improving function, symptom management, particularly related to pain and dyspnea. There's a cluster around immunizations, and there's a cluster around admissions and ED. And of course, these are our top priority for particularly the admissions and ED part for any of your payers, so it's a high area of focus. So as I mentioned, there are some things that you do that are going to be important to quality across every measure. You can't really drive quality unless you have certain fundamental systems in place that are going to assure processes are carried out consistently and competently. And the 4 sort of cross-cutting areas that I'll talk about a little bit are having a quality improvement model that kind of drives continuous improvement. That's more than just auditing, but really linking data, information, training, all of the pieces that you need to have a continuous improvement process. Using your data, which we've heard from already, is going to be an important capability that you need for VBP, and then quality overall. Education and training to make sure that your quality strategies are implemented reliably, so every time, not just on a hit or miss basis, and then OASIS assessment and documentation. And I'll talk a little bit more about each of these. So you'll find more information and resource links on the VNAA Blueprint about these activities, but what our best practice work groups have recognized is that you can't just sort of go at it haphazardly. You need a model for figuring out how are we going to get things done, how do we identify priorities, how do we sustain the change once we've got it in place. And it's really having a systematic model that you can adopt to make sure that you're performing at a continuous improvement level. And I won't talk specifically about models, but there are several of them out there. The Institute for Healthcare Improvement, which the Norwell folks have already talked about in another context, and then HRSA and ARC and many others have QI models. And so what that looks like in practice is one of the presentations for our Blueprint work group was around was from organizations that had 5 stars, and they had comprehensive programs in place that included bullets like the ones we're seeing up here. So staff training overall, and then specific to measures, OASIS training and auditing, programs to make sure that your staff have the capabilities and competencies that the patient who's referred to you needs. Patient-defined goal setting, and always events to improve reliability, and that's particularly important around driving your patient experience scores, and then continuously looking at your data at multiple levels and using it to drive accountability. And this is kind of a way that organizations are packaging their quality programs. The second cross-cutting one, as Norwell has already said, is that using your data strategically is a really critical capability. So both looking at your data and then using it at the point of care to drive consistency in quality. So using your electronic alerts to tell people if they've missed something in the documentation. You can have gaps in care alerts. You can use predictive alerts, for example, for patients that are high risk of rehospitalization because of a variety of risk factors. And then also segmenting your data in different ways. So you might have daily reviews of patients that have been readmissions or patients that have gone to the ED, but then broader, looking at monthly, why did people go to the emergency room, why did they get readmitted, and figuring out if there's a bigger picture there that needs to be addressed in a quality improvement strategy. Using your data to set performance targets, so looking at your data compared to the state or to the national benchmarks and deciding where you want to try to achieve those VBP improvement points for your value-based purchasing score, looking how you benchmark against other organizations. So some organizations can do it themselves, some need a data analytics vendor, but just overall you need to be able to understand your data at very granular levels. And then I think it's increasingly important, it's probably always been important, but to show that you're delivering high quality performance. So if you've got the performance numbers that you're proud of, you should be telling all your payers about it and making sure that they know that you're an accountable partner within their healthcare system. And as more hospitals and health plans are looking at performance in the same way that CMS is, showing your data is a really critical capability. From our best practices work group, we hear that many of them are generating measurement reports weekly or at the very least monthly and sharing them with teams, so really involving staff members. And you'll have a quality team, but you'll also have your clinicians, and having them in the loop about how they're doing on performance is really important. Developing criteria for improvement, so like deciding where you want to be and what you're working towards is really important. And then also understanding which measures are driving your star ratings or your performance overall, and being able to focus in on the ones that are sort of high priority drivers. Let's see. So education and training, what you're training for is consistency. You are trying to make sure that staff understand the big picture, that quality is linked to reimbursement and to patient outcomes, and of course that they are a huge part of that, and that the organization really depends on them to help make sure that you're meeting your targets. So as we've heard from the Norwell folks, reinforcement of OASIS skills is really important. Another thing that we heard pretty regularly was recognition of high-performing staff. That could be through either financial, or it could also be just having employees of the month or gold star employees who get to wear a pin, things like that, that really make them feel that they're contributing to the overall performance of the organization. Many organizations have identified the need to teach skills for patient experience. So, we've always placed a high priority on compassionate interactions and empathy, but now really figuring out how do we do very specific tactics to improve performance around a patient experience. Using mentors and preceptors is something that organizations have always done, but figuring out how to use them cost effectively, either to solve a specific problem or to help a certain category of employee, like new staff or new nurses, that kind of thing. Recognizing that nursing and therapy both are held accountable for the same conditions of participation, med-rec and things like that, but have different training through their education program, and therefore may need more training on how to carry out those activities like the med-rec consistently and with the same performance criteria across different disciplines. And then making sure that your training is linked back to feedback so that staff will know how they're doing in these important value-based purchasing and quality metrics. And the final area of foundational or fundamental, and this is not news to you, I think everybody who is working in home health now knows that OASIS assessment is really sort of the baseline of your performance, that you need to have accurate OASIS assessments at start of care and then at discharge, so that patients that providers are consistently assessing and using the same coding across different types of start of care and care management nurses. So that means training for inter-rater reliability, where you can, maybe assigning the same clinician for start of care and discharge assessments, and then making sure that continuing education on OASIS is always a part of the organization's program. So, Suzanne and Andrea, can I turn it to you again to comment on sort of the foundations of quality?
So I do have a couple of comments. This is Suzanne. Just going back to your educate and train staff slide. We do provide a very comprehensive orientation. So we're very particular about who we hire into our home care agency, and we really try to hire the best people, not necessarily, we do try to get people who have as much experience as possible, of course, but also people who are very willing to learn, and we spend a lot of time with our new employees. We have preceptors and a preceptor training program that we put our preceptors through, and we make sure our preceptors are working closely with our new hires for a long period of time, depending on how much assistance they need, and also just doing a lot of in-house classes, making sure that they can do a cardiopulmonary assessment, they can do a wound assessment, they can get comped off on doing different kinds of wound skills. And they, of course, go through the OASIS classes and the Connect the Dots classes that I was talking about earlier. And we also have quite a significant number of online learning courses that they take too. So we do put a lot of effort into the training to try to make sure that our new hires get up to speed with all of our care of our patient and answering the questions, so that we do have great outcomes for patient experience and quality outcomes. And one of the other things I just want to mention that goes with that accurate OASIS assessment is just a reminder that while we're looking at a lot of outcomes, there's a lot of outcomes to look at, and they do go back to the OASIS. We do just need to remember that all the questions on the OASIS really do matter because of the risk adjustment that goes into your quality scores. So we do need to focus in on particular quality outcomes that might be an OASIS question. We still need to remember that the risk adjustment piece of it is important to make sure you're paying attention to as well.
And I would just like to add back to the slide relative to using your data strategically. You talked about the electronic alerts for gaps in care documentation. And again, we partner with a vendor relative to SHIP relative to getting alerts from our OASIS data. It's driven from our OASIS data relative to making sure if a patient is alerted for a referral to hospice or rehospitalization risk or a falls risk. But that's why we're also looking at other systems, as I talked about earlier, to identify those gaps within our documentation daily beyond the OASIS, so that again we can do early risk identification and be able to perform an intervention so that we can minimize that risk and hopefully prevent a rehospitalization. So we do review our data trends regularly in our QI meetings, as well at a minimum monthly, more often than that, and utilizing our team scorecards and clinician individual scorecards is an important factor in getting that data back down to the clinician and their performance.
And I'll just say just one more thing. Sorry, this is Suzanne again. I just wanted to also just mention documentation to support OASIS answers. That is kind of an area that we're really diving into right now, feeling that we need to make sure that we have good support, like of the dyspnea question, of the ambulation question, that to be able to support those answers on the OASIS questions.
Thank you.
Great. Thanks, you two. And I think that's kind of a theme of today's session is better understanding of your patient's risk, documenting that risk, and then using it to drive certain other measures like the readmission is going to be an important thing for organizations to be able to do going forward. So let's talk a little bit about some of the strategies recommended by the Blueprint work group in specific measure clusters. And managing daily activities is CMS's sort of umbrella term for some of the functional status measures. And in value-based purchasing, that's your ambulation and bed transferring and bathing measures. So these are interventions that probably are going to have an impact on that cluster of measures. And the work group identified some of the barriers, what's driving gaps in performance that you might be able to intervene on. So patients who are depressed, patients who have cognitive impairment, uneven engagement among your own home health agency staff and the patient plan of care, not getting rehab staff involved early enough, and that could either be because you are short-staffed, you're not getting a referral, or people don't think of making the referral, so there's like several areas of improvement around that. And then some patients really are maintenance patients. They may have limited opportunity for improvement, and that's not captured as well as many organizations would like in terms of the metrics, but it is something that you can try to capture through your OASIS documentation. So some of the activities they recommend around these functional status measures are making sure that all patients are screened for cognitive problems and depression, and that often means a referral related to those things when necessary. Getting therapy involved early, and particularly OT for many of the things like bathing would be an important one, and for some of the transferring. Developing a plan of care that emphasizes the functional status and making sure that all of the caregivers, including the patient's caregivers, the patient, and any home health agency staff or aides that are a part of it, are all sort of educated and aware of the plan of care, educating referral sources on the need for referred to rehab services, and then where staffing is an issue, short staffing, making sure that you have a source, it could be a temp agency or some other way of making arrangements to have additional staff, but making sure that you have a way to educate those people quickly and get them up to speed on your expectations and the measures that you'll be holding them to for functional status improvement. And I just wanted to kind of circle around and point out that the plan of care one, making sure that everyone understands the plan of care, that also will probably impact your patient experience measure. So you're educating the patient, you're finding out what their goals are, you're helping educate them on how you're helping them so that they can then feed that back to you through a positive patient experience rating. And Suzanne and Andrea, can I call on you again to comment on functional status measures?
Sure. Hi, this is Suzanne again. Just do want to comment that rehab staff is important to have involved in the activities of the managing daily activities. But I just want to remind people that as function declines, that person is much more likely to be hospitalized. And so we want to make sure not just rehab staff are focused on that, but that the nursing staff is very much focused on functional activity as well. And a lot of the OASIS questions, while there are certain ones that are managing daily activities, but they really involve function, and including the DISC score and the pain score really are asking you about the level of function or exertion that brings on those symptoms. So We really need to be making sure our nurses as well as our rehab staff are getting up the patient, moving and assessing function. And just as far as the cognitive, one of the things that we have put into place is Alzheimer's training. We have staff go through that as part of their orientation, a very significant class on Alzheimer's training that they need to complete. And then we also have a specialty team for Alzheimer's that is multidisciplinary and very great at going out and doing consultations on patients and talking with staff about patients that may have cognitive problems that could be affecting their ability to progress.
Great, thanks.
Thank you.
So why don't we go on to managing pain and treating symptoms, which are your pain and dyspnea measures. I'm going to try to move quickly because I can see that we may run out of time, but let's just continue on to some of the recommendations that came from the work group, which are getting the engagement of the clinicians within your organization through some kind of mechanisms like a nurse council who might develop pathways, who kind of embrace it and customize it for your own organization. Some organizations are making pain management or dyspnea management an always event, something that you always ask about a patient, each visit, including also having standardized assessments with numeric indicators. And those numeric indicators, if the patient is short of breath or in pain, might trigger a call to the physician or some kind of referral so that you have sort of quantitative ways to see how you're doing with the patients. Many organizations are developing relationships with palliative care nurses or palliative care physician groups and are also providing additional training to their own staff through groups like LNEC, which is a specialized training group, making sure that you have improved responsiveness with the PCP or other physician, for example, by using SBAR to try to get faster, more systematic communications and changes in protocols back from the physicians. And then working with your referral sources on sort of how pain, dyspnea, functional status are all interconnected and the need to keep rehab staff involved. One of the organizations that presented to our work group had a comprehensive package that they put in place because they felt like this was a big driver of their performance and also of things like rehospitalization, as we've heard. So they did a comprehensive re-education of their clinical teams about screening for pain and dyspnea. They had a drive to increase referrals to physical therapy for helping to manage pain and dyspnea. They looked at their data to see what was behind, their own analytics and there's, downstream things like rehospitalizations and ED use. For patients that were high risk and they had criteria for that, they would do front loading of visits and things to try to really get pain and dyspnea under control early on so that they didn't see downstream side effects. Working with the hospitals, they tried to get patient education sort of consistent so that the hospital and the home health care agency would be giving similar patient information and consistent messaging about managing pain and dyspnea, and they implemented a better breathing program. So they really felt like pain and dyspnea were a package that they could work on together. And Andrea and Suzanne, what have you done in Norwell?
This is Andrea. I'd like to speak to, again, the management of pain and dyspnea assessment here in training and education was, we identified that early on, and we did a very comprehensive pain training and education to our staff led by our palliative nurse practitioner. She was really the driver of that to really provide more in-depth education to our staff on the management of pain and really looking at our validated pain assessment tools such as the pain thermometer and really making sure that staff had that intense training, if you will, for that. Also, we're looking at developing our palliative care nurse team, additional nurses on that team who want to develop that specialty skill set and providing additional education through the HIPNA, the Hospice and Palliative Care Nurse Association, looking at their training modules to provide them with that type of additional targeted training specific to the management of palliative care patients and pain and symptom monitoring and assessment. Thank you.
Great. Thank you. So let's look at vaccinations, and our work groups look specifically at flu shots, but I think a lot of the cross-cutting interventions could be applied to the herpes zosters and the pneumococcal as well. So some of the barriers around high achievement around vaccinations are coordinating with other practitioners on getting people the shots, finding records of the shots, making sure that everyone understands the specification for the measures, what is the current flu season, patients refusing, providers not thinking it's a priority, and now that you've got staff vaccines as a part of it, I think staff refusals or reluctance might also be an issue. So some of the best practices that organizations do to kind of nail this measure or these measures as it now stands is making sure you get flu shot or a pneumococcal shot information with referral information wherever you can, and filling any gaps on the initial assessment, having these embedded in the health records as mandatory fields, figuring out very specific and standardized protocols for following up with shots. That could be through standing orders, referrals to another site where the patient could get the vaccine, using standing orders in states where that's allowed, and we understand that that's not everywhere, so that many agencies will have to have workarounds where they can't get standing orders. Having designated, dedicated staff to follow up with providers where if there's missing information, contacting the provider to get the information. A few organizations are doing shot days where they'll have one nurse go around to all the patients who are missing shots in their homes and give the shots to do the catch-up, educating staff, and then for the refusal issue, there's a lot of really great resources out there. The CDC has quite a few websites and patient information resources out there, and so using those to help you with the education of staff and with patients. And NVNA folks, do you have comments on the vaccination strategy overall?
Not specifically, other than, again, relative to management of our staff, volunteers, students. We have a lot of students who rotate here for clinical experiences to ensure that we, again, have a tight process in place, utilizing our Board of Health to help oversee that, to make sure that that compliance is there and to collect that type of data. We do provide, again, looking to education, the VNAA best practices on pneumonia. We've utilized that for education and training for our staff to ensure, again, that they're following up and making sure that that immunization history has been collected, and assessed and collected. So that's been a great resource.
Thank you. Okay, so let's talk a little bit about unplanned hospital care, and that captures both your readmissions measures and your ED use. And some of the drivers behind that are patients being discharged early without an infrastructure in place to provide adequate care for them at home, high-risk patients, and those are the ones you want to identify early and try to get some intensive services to them early. Physicians who tell patients to go back to the emergency department, and maybe patients who don't know other options when they are feeling anxious or having symptoms. Lack of access to outpatient urgent care, or patient and caregiver anxiety or lack of knowledge. So those are some of the things you want to target with your interventions. Some of the best practices that came up through our work groups were things that we've said before in terms of identifying the high-risk patients so that you can know who's at risk and try to get with them early. Getting more intensive services to the high-risk patients, which includes potentially front-loading your visits, linking them with private duty, helping them identify other caregivers, so other kinds of things that you can do to monitor, arranging for home care physicians and nurse practitioners, and we're actually seeing quite a number of home care agencies now using nurse practitioners to try to impact this unplanned hospital care measure. Improving relationships with your hospital to try to get better preparation before the patient does come home, so being a part of the discharge planning process with the hospital. Again, the SBAR communication so that you can interface with the physicians more rapidly when a patient does have an urgent issue. Looking at your data to figure out what's driving your ED use or your admissions data, and it's quite frequently respiratory issues, and try to get on top of those. Developing better transitions and handoffs, educating your staff and patients on what to do when there's an emergency or when they're having symptom exacerbation, so that many organizations are using things like Call Me First tools for patients who are having non-acute emergencies but who are having symptom exacerbation, so that they have some choices besides going to the ED and showing up and potentially being readmitted. And then using technology, which we've also heard from Norwell that they're doing around telemonitoring and trying to both have biometric information, but also potentially using remote visits to engage with them as necessary. And then I'm going to go right on to patient experience, and we'll stop once more to get Norwell's perspective. But sort of the last critical area that we haven't talked about so far is this patient experience cluster of measures. And these measures drive a lot of the overall performance of the agency. And what are some of the barriers? You know, inconsistent experiences with the way staff practice, lack of customer service perspective, so it might be little things like not returning phone calls or too many transitions among staff members going into the home. Some patients are perceived as difficult, and it might be more challenging to manage their experience. And then patients who have cognitive barriers may have a harder time both reporting on experience and having you impact their experience. So some of the things we've seen our members doing are looking at always events, and we've talked a little bit about those. It's a concept created by the Institute for Healthcare Improvement, or IHI, which is, again, driving towards consistency, but in this case it's consistency around patient experience. So asking the patients, what is your goal for today, how can we help you, and making sure that we always do that each time so that the patient feels understood and taken care of. Understanding the customer needs from the agency perspective, so many organizations are doing outbound calls at specific intervals to find out, you know, how things are going, is there anything they need, and of course you would do it if a complaint comes inbound to you as well. You might have an agency leader for customer service, someone who's kind of dedicated to looking at the data and looking at trends that might be impacting patient experience and making sure that those things are part of your quality improvement strategy. Implementing quality improvements in areas where pretty consistently agencies have a hard time managing the patient experience, which is around scheduling, returning calls, staff turnover, making sure that patients know who's coming when, you know, getting introductions when the staff turns over, that kinds of thing. And that's where handoffs planning might come into place. So when the clinician is going to turn over, the different nurse is going to come out, that, you know, you tell the patient that that's what's going to happen, and you help do introductions and make sure the caregivers know, so that there are formalized processes for that within your organization. Customer service training is another element of it, so that you might script working with a difficult patient or handling an angry caregiver or something like that, so that people have strategies that they can pull into place when they need it, when they're dealing with someone who may be perceived as more difficult. And then documenting the patient goals with the patient and feeding them back to the patient so that they know that you're thinking about their experience and their goals, and that you're addressing them, so that they can report that back when they're responding to the CAHPS survey. So those are some of the things that the organizations are doing, and one of our members, Sutter Care, has really focused in on this always event approach and feels like it really makes the patient feel taken care of, and it helps really make sure that you're targeting your services towards what their goals are and driving improvements in that patient experience. So that's one of their best practice recommendations. And so, Norwell, can I ask you to talk a little bit about your readmissions activities and your patient experience?
Hi, this is Suzanne. Yes, I wanted to mention our clinical pathways, which we used in order to, take care of the patient well and keep them out of the hospital and out of the emergency department. So we've been using clinical pathways for heart failure, COPD, diabetes, and our joint replacement they were developed by the Visiting Nurse Association of New England, and I know that you, as a VNAA, has worked very closely with the Visiting Nurse Association of New England to incorporate those pathways into your blueprint for excellence. And so we've tried to make sure that all of our clinicians are following these pathways. One of the things that are also a part of that pathway is what we are calling a pathway phone call. And that is a phone call out to any patients who have those diagnoses prior to the first start of care visit. So we have the particular people, perhaps our like telehealth nurse, making calls out to our COPD and heart failure patients, making sure that they are that they're able to take care of themselves overnight, that they have all the medications that they need to take, and that they are going to be safe until we get out there to do a visit and to assess them to see whether or not they might need an earlier start of care visit. The pathways also incorporate some of our protocols that we have put in place on making sure we front load visits and involve telehealth, and we talked a lot about that earlier, but front load visits particularly with our patients with the COHF and COPD. We also utilize our nurse practitioners as a way of looking at charts, consulting with patients, monitoring them through telehealth, and then going out and doing assessments with our nurses out in the field. So those are some of the other ways that we are trying to keep patients out of the hospital that we haven't mentioned yet. As far as our patient satisfaction surveys and experience, again, we try to make sure that our clinicians are very well aware of what the survey is that's being sent out to our patients. So they have all seen copies of that survey and how those questions are grouped into composite scores and the universal scores, so they're well versed on the whole process and understanding that this is going to be impacting and that we're going to be paid on the quality of our patient experience as well as our quality outcomes. So that's been our focus most recently with patient experience.
Thank you.
Great, thank you very much. So we're getting close to the end, and we just wanted to provide you with a couple of takeaways from both the blueprint and the discussion today. Pretty fundamental, know your data and use it for all aspects of your quality improvement and working with payers and value-based purchasing partners. Make sure that you have your fundamentals in place, your OASIS, your training, patient experience, and then look at specific measures and where your gaps are occurring and how you can deploy resources to work on those. You may need to prioritize because there's a lot of measures out there. When you can clump things together, it makes sense, but sometimes you have to just know which ones are driving your performance in the highest level and focus in on those, and then get to others when your timing makes it more of a possibility. So stay focused in spite of all those competing priorities. Of course, you're home care agency, so you keep the patient at the center, but make sure that all of the staff remember that, because not only is it part of your mission, but it's part of patient experience and all the measures that relate to that. And if you would like more details, we encourage organizations to visit the VNAA Blueprint. We are actually having a workshop on value-based purchasing at the annual meeting of the VNAA in April, and of course any organization is cordially invited to participate in that. You can reach us by email if you'd like to ask additional questions, and we probably have time for a couple of questions via the chat button. We did get one or two, so if you have a question, send it to us via the chat button right now. We'll answer as many as we can in the remaining time, and we'll get back to you if we have a question that we can't answer. And last but not least, I wanted to invite everyone to participate on the next and final webinar in the Value-Based Purchasing webinar series co-hosted by VNAA and the Alliance. It's March 17th, Customizing Your QAPI, and Margarita Lapson with the Joint Commission will be presenting for us. So I'm going to end the formal part, as I know some people may need to drop off at the top of the hour. I'd like to thank our presenters, Suzanne Clark and Andrea Foley, as well as the Alliance for co-hosting with us. This has proven to be a very popular webinar series. We really appreciate the Norwell folks joining us today to provide the information from the field, and the Alliance for collaborating with VNAA on presenting. So thank you, everyone. We will answer a few questions now, but if you need to drop off, we're at the end of the formal content. And the first question that came in was around how often would you capture pain and dyspnea monitoring information? So if you do vital signs daily, do you monitor pain and dyspnea daily as well? And would it be for all disease states or just some disease states? And I'll give my take on it and then turn it over to the Norwell team. I would say that you first do your screening to find out if that's an issue for the patient. And if it is an ongoing issue, then I would say yes, whenever you do vital signs, you would do the pain and dyspnea screening. And it wouldn't be specific to the disease state as much as it is specific to whether the patient triggered that issue for themselves. And then you would monitor it regularly and make sure that you're driving improvements in it as well. But Andrea, Suzanne, do you have a different take on that?
Hi, Liza. No, I echo your same feedback relative to that. I mean, it's definitely the screening is most important to begin with, and as pain isn't always as a fifth vital sign. I mean, you're always going to be assessing and monitoring for that and collecting that data. So I would agree with you, the same recommendations.
And then Suzanne, I'll just even take a mention. I've been big on dyspnea as a symptom lately, and I just feel that is something to be thinking about too. Many of our patients, even though they might have been coming on with a primary diagnosis of something like they had a fall or something, many of them have multiple medical conditions, complex medical conditions, and that is also another symptom just to be monitoring on a regular basis of change, because that could be an indication of a CHF or COPD exacerbation. So something to be monitoring definitely on a regular basis, on an every visit basis if possible.
Great, thank you. Are there other questions? Heather, did any questions come into you?
I believe that I have sent you everything that I have.
Here's another one. Is Norwell VNA sharing HCAHPS results with patients, or HCAHPS the instrument? Do you want to just say what you do share with the patient and how you interface with the patient on HCAHPS?
Well, regularly that we as part of our orientation, we certainly staff are educated to the fact that patients receive a satisfaction survey, so that the staff out in the field will then inform our patients that they could randomly be selected and be receiving those, and if they have any questions about them, if they have a document that they've received a satisfaction survey, that if there's any questions that they can help support, that they certainly can help clarify relative to that.
We don't go and give them a survey though. The patient. We don't give them a copy of it.
So you lay the groundwork to show them the survey. Okay. And another question for Norwell, when you're using telehealth, do your clinical pathways change if telehealth is involved?
Our pathways speak to number of contacts, not number of visits. So that could be counted as if it was a particular contact with the patient, direct contact, not that they just gave their vital signs in, but if the telehealth nurse needed to have a contact with that patient, that could be counted as a number of contacts. So that answers the question well enough.
Do your patients on telehealth tend to have more contacts than patients who are just getting face-to-face visits?
Obviously, if they're having issues, they're having more contacts because so we're not going to limit the number of contacts that a patient has. So I would possibly, I would think that some people were put on the telehealth because of the need for more closer monitoring, and so therefore they would just have more contacts than somebody who would not be on a telehealth unit.
Okay, there was one last question about finding the previous webinars, and when we send out the PowerPoint presentation to the registration list of this webinar, we'll send you a link to VNAA's Learning Management System where you can find the previous webinar recordings. You'll need to register for the Learning Management System, but for VNAA and Alliance members, access will be free after you're registered. So with that, I'm going to close the webinar, and again, I'd like to thank Suzanne Clark and Andrea Foley. That was really helpful to hear how things are working in your organization and the very specific activities you're doing to manage value-based purchasing measures along with your quality improvement program. So thank you very much for your participation. And retroactively, I'd like to thank our VNAA Best Practice Work Group, whose ideas I was reflecting in my presentation today, as well as Heather Corbin, our Director of Education, Teresa Lee, the Executive Director of the Alliance, and all of you for participating in the call today. So thank you very much, and we will adjourn now.
Thank you.